think what I'll do, I'll start. There's still a few more coming in. I'll just give a brief introduction to the webinar. So first of all, my name is John Jones. I'm the team leader for Project 81, BioSec, which is improving the management of biosecurity risks in Southeast Asia. Many of you know me already. This is one in a series of webinars that we've been presenting, designed to support countries in the region, particularly Southeast Asia, in developing surge capacity to deal with pandemics. And we've had a look at a number of aspects to that. So I won't say too much about today's session because I'm delighted Dr. Jane Shallcross is with us, and she'll be giving a presentation just now. But we have a few housekeeping rules that I'd like to mention to you. As this is set up as a webinar, it's not like a traditional Zoom meeting, so we won't be able to see you, unfortunately. I can see your names on the attendee list, but there isn't that level of interactivity as you would have with a Zoom meeting. Nevertheless, there is a chat function, a raise hand function, and a Q&A function. All of which I would encourage you to use during the course of the webinar if you have questions to ask, and so on. If there's an opportunity at the end, if time allows, I'm quite happy to allow you to come in and go live and place your question directly to me or to Jane or to any of the panelists in due course. But we'll do that a little bit later. So the agenda for this morning, in a short time, we'll have a message from the head of secretariat for the Center of Excellence Initiative based in Manila, and I know Louis is preparing the recorded message for you now, so we'll do that in a moment. I'll then hand over to Dr. Jane Shallcross for her main presentation, and I'll probably give a little bit of an overview of the work packages in Project 81 first, before Jane kicks off with her, just to put the overall context in place. And then we'll have Jane's presentation, and we'll have some Q&A, and we'll have some discussion. The webinar itself is designed to run for an hour and 15, and I experience from previous webinars that is about right. We sometimes run to an hour and a half if there are lots of questions and lots of discussion. But I think it's only fair to everybody that I close it off at the 90-minute stage, and just rest assured that any questions that do come up, we will address later if we can't do them live during the session this morning. So I think perhaps at this point, Louis, I wonder if you're able to share the screen and give the welcoming message from General Castellan. Thank you.
To our colleagues in Europe and colleagues in Asia, good morning. Magandang umaga po from the Philippines. To Mr. John Jones, team leader of Project 81, Mr. Alexander Hamilton, Uniquely CBRN regional coordinator, whom I had the pleasure of finally meeting here in Manila, Mr. Balaz Mar, the EU Regional Cooperation Officer for Southeast Asia, national focal points, partners, guests, and participants, thank you for joining today's webinar. This is the fourth webinar organized under Project 81, which aims to strengthen biosecurity measures in Southeast Asia. Today, we shall hear from a subject matter expert who will discuss the Laboratory Biosafety Manual of the World Health Organization. It is intended for public health practitioners, laboratory managers, and colleagues from the Health Ministry. The Lab Biosafety Manual contains evidence and risk-based approach of optimizing resources and ensuring sustainable biosafety and biosecurity policies and practices. The goal is to enable equitable access to clinical and public health laboratory tests and biomedical research opportunities without compromising safety. Amidst the global pandemic we face now, the importance of establishing adequate biosafety and biosecurity measures cannot be overemphasized. Governments and policymakers have the responsibility of protecting public health from any outbreak of diseases, and we must work to ensure preparedness at the local, regional, and national levels. With that, we hope this webinar will cater to your needs and provide you with relevant information to mitigate biological risks and threats. On behalf of the EU CBRN Center of Excellence Regional Secretariat for Southeast Asia, I welcome you to today's webinar, and I hope you will find the discussions insightful. Thank you very much, and may I turn over the floor to our moderator. Mabuhay po kayong lahat.
Well, thank you, and salamat to the head of secretariat. Thank you for that message and those warm words. Yeah, and great now that the general is able to meet Alex in person, and he's now in Manila and operating. So great. Thanks, Alex, for joining us. I know Sabah has joined us also from Singapore, and Balash. Welcome to Balash from Bangkok now. So we have a few on the panel. What I'd like to do now, if I may, is just give you a very short presentation. I'm not going to spend a lot of time. I just want to give a quick overview of the project, because there will be some people who've dialed in for the first time today and who may not be aware of the overall context. So I just want to explain that. So I'll just share my screen quickly, and I'll play this slideshow through. Let's just put that in present mode. Okay, there we go. So, I mean, this work package is work package 7. So the series of webinars that I mentioned at the beginning, of which this is one, is about developing surge capacity for pandemics. This was a new work package that was added to the project some time ago when the pandemic was at its height. And so the original concept of Project 81 was to have these 6 work packages, basically. So first one, raising awareness of the risks and emanating from biohazards, particularly with a security angle on it. Work package 2 was reviewing the national legislation and the guidelines to see how pathogens are controlled within the various countries. Work package 3, strengthening the level of enforcement. So if the laws are in place, how do we enforce them? And this is very much a training package, training our trainers within the countries to be able to carry out enforcement of biosecurity legislation. Work package 4 looks at inventories, national holdings of pathogens, high-risk pathogens, how they're managed, and how that information is maintained and shared. Work package 5, improving laboratory capacity to identify types and causes of biosecurity incidents. And then finally, work package 6 was a little bit more about physical security at facilities and cybersecurity. Well, I won't call it cybersecurity, but protecting information that relates to hazardous material, hazardous biological material and pathogens. So those are the six work packages. Work package 7, the 7th one, the one we're dealing with today, was added and is about developing surge capacity to deal with pandemics. And with that in mind, with today's presentation, I'll hand over to Jane shortly, but with today's presentation, we're killing 2 birds with 1 stone, because we want to look at the impact of the Laboratory Biosafety Manual Edition 4, produced by the World Health Organization, the impact that's having on the management of pathogens, and also tie that into what effect that might have on outbreaks and future outbreaks, and we'll run through that with Jane in a moment. So that's the overall context. The project's still got a couple of years to run, and we can't do much of this at the moment because of the pandemic itself. So bear with us. We're going to try and proceed with face-to-face meetings as soon as we possibly can. In the meantime, we're offering webinars, and I do hope to be able to get to the region in December, but it all depends on the pandemic, of course. So there we are. That's the statement of intent for Work Package 7. So we've looked at a number of aspects of what surge capacity might contain, and we've already looked at waste management. We've looked at diagnosis. We've looked at capacity at laboratories, and today's session is looking at our procedures and the risk management associated with outbreaks. So we'll have a look at that. I would encourage you to use the chat line. Some people are already using the chat. I can see lots of welcoming messages there. We've got the Q&A that you can use. If during the presentations we'll have some polls, actually, so we'll have some questions for you, interactive polls, which we'd like you to participate in. If you have any comments additional to the answers that you've given in the polls, please use the question and answer box, and we'll try and either address them by typing back to you, or if we can do it live at the end of the session, we'll do that also. So I think I'll stop sharing at this point. There we go. And introduce Dr. Jane Shallcross. I was going to call it Public Health England, but it's not that anymore. It's UK Health Security Agency. Have I got that right, Jane? I think you're on mute.
Thank you. We're all getting used to the new terminology. We changed from PHE to UKHSA at the beginning of October. So yeah, it's new to us too. Can I just check that my screen is showing properly, John?
Yeah, that's fine. That's good. Thanks, Jane. Yeah.
All right, thank you very much. Well, thank you all for the warm welcome, and I'm delighted to be with you today and share my views on outbreak preparedness and how the new WHO Biosafety Manual 4 will help us, especially with outbreak preparedness and resilience as we move forward. So just to give you an introduction to myself, I am a country girl. I was born and raised in the in sort of villages in the south of England on farms. I did a degree in biomedical sciences and then a PhD on the detection of Listeria monocytogenes. And then I've worked in research centres. I've worked in London at the Laboratory of Government Chemists. And then in the late 1990s, I moved back to my roots in Wiltshire and started working at Porton Down at on the site that is more to do with public health rather than the military site, which is over a fence. So our organisation is, I've got a very long track record in high containment microbiology. And so I started as a research scientist here and then transferred over to set up a training team in the early 200s. And to back this up, I did a postgraduate certificate in education as a training qualification to help me in that role. So I'm now, I've been head of the Novel and Dangerous Pathogens Training Group for many years now. Me and my colleague Alan Bennett were very privileged to be given or apply for the WHO Collaboration Centre status for applied biosafety and training. And so I'm a co-head in that. And our training team design, deliver, and practical laboratory applied training in the UK. And then with this WHO role, we have a worldwide outlook too. So we deliver training in containment level 3 for biosafety officers, but we've been involved in a lot of training in many different countries. One of the main projects was the Ebola training for the PHE laboratories in Sierra Leone, which I'll talk about later. But we've also had the pleasure of going to Thailand to run training for the WHO Southeast Regional network in Train the Trainer. So maybe I met some of you there. More recently, I was a lead author on the WHO monograph for Outbreak Preparedness. And then with COVID, normal training has really stopped. I helped set up a diagnostic lab here at Porton, which is a national resilience centre. We've done a huge amount of COVID training for our own staff, for staff who've been deploying to support other laboratories, and we provided e-learning for WHO. And I was also led a project where we first tried the lateral flow test in for asymptomatic testing. And so far, at the moment, we're just being required to do lots and lots of training as well. Another interest of mine is some emergency preparedness, and I have designed and provided training and support for a decontamination team on site, and also laboratory first aid in high containment. But I'm for your interest. Okay, so in this talk, I want to review the outbreaks and previous responses that I've been involved in, and that you may well have been involved in too. From that, the lessons we've learned and how we can apply that to risk assessing laboratory responses, and how the WHO Laboratory Safety Manual 4 risk assessment strategy sets out and can be utilised. And then I want to have a brief look at lessons from COVID-19 and the types of laboratories required for outbreak response. So this is a very large topic, and we've got about 45 minutes. So I will give you some, I'll promote some literature and things that you can review to get more information if you're interested.
Jane, I wonder at this point before we launch, shall I just launch the poll so we can find out who we've got in the audience in terms of? Yeah,
yes, please, that would be great.
Let me do that now, and then let me launch the poll. So a quick poll for everybody to answer, which will ask you what your role is. Single choice. I think it'll be obvious when I launch it how to answer. But we tend to do this during our webinars to engage with the audience. So I think probably at a good point in the session to launch the poll and just find out a little bit about your background. So quite a few coming through now. I'll give this a couple of minutes.
What would you be ticking, John, on this one?
Yeah, that's a good question. Other, I think other covers
You're
everything.
in other, yeah.
When I was working in the Home Office, I would have been a policy official, I suppose, but now I'm a consultant. I'm definitely an other.
Yeah.
Okay, so we've got 71% have come through, so I'll just give it a little bit longer, and then we'll see what. I think that's probably as what we're going to do. Okay, I'll end the poll now because we've got plenty to talk about. Let's just have a look, and I'll share the results. There you go. So we've got a mixture. We've got a good mixture, actually. Broad spread. We've got lots of others, but we've got lab technicians, lab managers, policy officials, one or two clinicians there, some research scientists, and some others. I know we've got representatives from other countries actually here. So outside of Southeast Asia, so that's always good. But anyway, thanks very much. So I think we've got the right audience, Jane. So let's proceed with the talk. I should warn you that I think I might have missed one of your polls out in one of the questions that comes up because I had a bit of a nightmare last night trying to get the polls right. But I'm sure we'll get there. Back to you anyway.
All right. Thank you very much. So if we just first of all define what an outbreak is. So an outbreak occurs when either a new pathogen emerges into a population. So an example could be MERS or SARS. So these weren't previously known and suddenly they're there. It could be an existing pathogen that emerges into a new population. such as Zika, which used to be, which was known about in Africa and Southeast Asia, but had never been known in South America. And then we have an outbreak can be where the number of cases of a known pathogen swiftly rises above the normal range. So examples could be meningitis or yellow fever. So there's different types of outbreak, as I've just described, and then there's different stages of the outbreak. There's the pre-outbreak. So this is when we want to be doing the research, we want to be surveillance, we want to be understanding the pathogens and hopefully developing new therapies and vaccines for potential emerging pathogens. We'll get the first cases, so the individual cases, the small clusters. Then we'll go to, well, hopefully the outbreak will be controlled there. If not, we get to widespread disease. Hopefully then to outbreak control, and then eventually to post-outbreak. So these stages will look very different for different outbreaks. And unfortunately, with COVID-19, we are still in the widespread disease part of the outbreak. And I think we will be until all the world has managed to have the medicines, vaccines, or control measures in place to control the outbreak. Okay, so this is our first poll that we have, and I was just really interested to know what outbreaks you've been involved with, or do you remember? And if we do the outbreaks you've experienced would be good. And if you've got an other, then I'd be really interested if you could write that in the chat.
Yeah, lots of, so, I mean, I think there's an obvious answer to this one, Jane, but which one? I'll give you an easy one. Which one do you think is going to be the top answer?
I think SARS-CoV-2 has been dominating all of our lives, hasn't it? Really, for the last almost 2 years now, coming up to yeah.
Okay. So I've had one question, one chat in actually, and that's Ebola Reston. Is that well, Ebola, I guess. Yeah. Yeah, that's
excellent.
Somebody from the Philippines, I think. Edson. Yeah. We've got a few more coming through. I think
presumably that scientist deployed to Africa or was part of the response there.
Yeah, we've got Adrienne Rashford has just said it was. Sorry, I should have put that multiple choice. I didn't. So that's
okay.
That's my fault. So okay. So with dengue, measles, we've got coming in another Ebola. So interesting spread. No one's come up with Zika, which is interesting. But maybe it's a function of the fact that I didn't put the multiple choice on. Unfortunately for that one, that's my fault.
Or maybe within the Southeast Asia region, it's considered endemic and not an outbreak. With the sort of few cases that come up.
Yeah. Anyway, here's the poll. Here's the answers. There we go. So SARS-CoV-1, a few. MERS, and it's going back a few years now, isn't it? MERS.
John, I can't see your answers there.
Okay.
Oh, that's it.
That's my fault again. Operator error, as they say. So yeah, SARS-CoV-1, MERS, H1N1, of course, CoV-2, and then one or two others. And as I say in the chat, we've got dengue, Nipah, that's just come in as well. So yeah, quite an interesting spread.
Yeah,
but yeah.
It's a shame it's not a chat because I could divulge here and have a good chat with you all about the different responses.
Okay, let me stop sharing that one.
For myself, COVID-2 has been the one that COVID-19 has been the one that obviously has been the major response. With Zika, swine flu, MERS, CoV, SARS-CoV-1. We've worked on all of them here at Porton, but it was more sort of travel associated for CoV-1, MERS, and Zika, and the swine flu. I'll talk about later in our response.
Okay, back to you then.
Thank you. Yeah, thank you. So there's some outbreaks that will affect enormous groups of people or have the potential to cause pandemics or worldwide response. And so the WHO can call a public health emergency of international concern. And the purpose of this is to focus attention on the acute public health risks that have potential to cross borders and threaten people worldwide and require a coordinated mobilization of extraordinary resources by the international community. And since IHR was put into place, we've seen 6 PHEICs announced. So the swine flu, polio is still ongoing because any case of polio would be considered under the definitions of this. And then there's been the 2 Ebola outbreaks that have been classified, Zika, and then obviously COVID-19 that we're in now. But as we sort of saw from some of your answers, looking at measles and other outbreaks that you've been involved in, it can be there's a local perspective to this, and the WHO produced the Disease Outbreak News, which shows outbreaks in local regional areas. So these will affect the countries that are where these cases occur, but and scientists from around the world will be looking at these and monitoring these and looking at interventions to help or to respond or to monitor travellers who come in from these areas. But it's when the public health WHO raised the standards that everybody can come in and help with these responses when required. So just to review some of the outbreaks that we've been happened during my lifetime. I suppose the first one I was aware of was HIV/AIDS, which was an emergent pathogen, so it hadn't been known of before. It was a sort of new, almost species of virus that we had to learn about very quickly in the controls. We had the first SARS pandemic, another emergent, didn't particularly affect the UK, and we didn't learn as many lessons as many countries in Southeast Asia did at the time from the wonderful response that Southeast Asia mounted to COVID-1, sorry, that should say. Anthrax, so there was the deliberate release in the USA. In the UK in 2009, we had an outbreak amongst intravenous drug users, and I'll talk about that in a bit more detail later. We've had swine flu, which was a reassortment, stroke emergent. Cholera was thought to be introduced in Haiti by volunteers or military from Nepal who came to help in the response, and so was a new population that is infected. And so we go on. So you can see there's a whole mix of emergent new populations and reassortments there. So when I think back to the outbreaks that we've been involved in, they've all had different characteristics. So we just quickly review these to look at some of the different types of responses that are needed to outbreaks. So with swine flu in the UK, we had to set up the assays very quickly. It was local hospital-based laboratories that responded. Initially, they were inundated with samples to process. And so we had scientists deploying to those local labs to increase the number of hours that the labs could run and the number of samples that they could run. But it was based on the local labs responding. And very quickly, the strategy, the labs were overwhelmed, and the strategy was to only test people who were admitted to hospital, and non-hospital cases were diagnosed on symptoms alone. And as they were little asymptomatic transmission, this testing was enough to, with other controls, that the health system didn't get overwhelmed and the outbreak didn't continue in an outbreak phase for sort of too long. And the outcome for the labs was initially, there was great interest in the labs initially, and there was some more funding, and it led to a sort of review of systems and an increase in automation. But then in 2008, we had the sort of national, the economic crash, and since then we've had year-on-year budget cuts of about 10% per year. So the labs have been underfunded, basically. When we look at the response to anthrax, so just a bit of background here. So there was some batches of heroin that they think were wrapped in skins to confuse sniffer dogs and to disguise the heroin as it was imported into the UK. And it's thought that the heroin was contaminated by anthrax by cross-contamination from the skins. And so the heroin was sold on the black market and injected into or used by heroin users in the UK. And there were 51 cases and 14 deaths. There was cases of meningitis, and also in this picture here, you can see some sort of very different systems from the sort of cutaneous anthrax you might see from more from traditionally acquired anthracis, where you just see like a black eschar. Here we see huge edema and infections. Now, all these samples, they needed to be processed and treated forensically because there could be criminal prosecution. So we had large amounts of heroin being brought onto site that we needed to test to see if it was those batches that contained the anthrax. And then we also had a mixture of blood, EDTA, blood serum, tissues, and other samples to process. And this range of sample types, all done under high containment, made the response really quite tricky. And all of the samples were handled in class 3 cabinets. So, which, although gives a very good confidence in user protection, is quite a slow and laborious way of working. So there was there's not many scientists in the UK who are routinely working on anthrax. It's quite a small niche thing. And so there was a lot of pressure on a small number of scientists, especially for the first 6 months of work. And the training to work at this level, takes quite some time. So it's difficult to expand very quickly. Also, you've got to have all the security and obey all the restrictions for working with animal pathogens as well. And plus, it's a spore former, so it's more difficult to inactivate samples as well. So, although, a discrete outbreak, it did cause us quite a few problems. So the next outbreak I quickly want to discuss is our experience of the outbreak with Ebola. So PHE as we were, deployed 3 laboratories to Sierra Leone. And we also worked with the EU Mobile Lab out in Guinea as well, and Liberia. So in our 3 PHE labs, we had teams of 16 people who deployed for up to 5 weeks at a time. As well as the laboratories, we had Ebola treatment centres, and medics were deploying to work in the Ebola treatment centres. And so when this outbreak first happened, there were relatively few experts in infectious disease, PPE protocols, and lab design. And so those experts were working night and day to make proposals and procedures and risk assessments and define PPE protocols, etc., for both the medical and laboratory teams that were deploying. And I think we were asked to respond in late August, and the first teams just went out at the very beginning of October. So during that time, we had to build a mock lab at our site at Porton, develop all the SOPs, develop the risk assessments, do the military training, and train the first set of people who went out to the first laboratory. And then the response went on for 18 months. So we would be training batches of 16 scientists week on week on the methods to deploy. And it worked very well doing the training back at our base in the UK before people deployed to West Africa. There was a huge cultural shock for people who went from the UK to West Africa. What they reported was the one place that felt familiar was inside the lab, because they'd spent a week in our training lab that completely mimicked the labs in West Africa, and they knew the procedures inside out, they knew the risk assessments, they knew the workflows, and so that they could apply their knowledge there. Yeah. The third picture, so this picture here is inside one of our PHE labs, where we worked in a lab within a lab procedure in these flexible film isolators. So all the active work on the agents before they, from opening the samples to inactivation, happened inside these flexible film isolators. The samples could be surface decontaminated. You can't quite see the, there's a pass box on the side of these cabinets, but then pass through into the pass box, and then the RNA extraction would be finished on the bench. This picture here is of the tented European mobile labs, where they have much smaller glove boxes that they use, and then these, so the samples are still contained as they work. And this was the lab that I deployed to, which was a Dutch laboratory that was placed in on the borders of Sierra Leone and Liberia, and had a class 3 cabinet in that we used there. Okay, so what were the drivers to change to develop this biosafety manual for? Well, wealthy countries will make their categories of agents and define them into risk groups, and then define the lab requirements that they need to deal with those agents to protect the laboratory workers and prevent release. And in those developed countries, there are some weaknesses to the system, but it has worked quite well. So, one of the weaknesses is that you get agents that are vastly, or pathogens that are vastly different, with the same risk group, that don't require the same laboratory infrastructure, such as hepatitis C and TB. And these labs are expensive to maintain and to use. So we've got a question here about using the level 4 manual. So I'm just really interested to first of all find out how many of you are aware of it and have read it, and where our starting point is today. Thank you, John, for the question.
I managed to just expand on the slide a little bit, so there's a few more questions in there, as you can see. But there's quite a range of answers coming in. When did the LBM4? When was it published, Jane?
It was December 2020.
Okay.
It was sort of over the Christmas break. So so when we wrote it, I think we started writing in 2017, and then sort of finished it 2018, 19, sort of late 2018, 19, and then it had to go through all the reviewing stages at the WHO, and then we had COVID-19, and so we reviewed our monograph to see if it was true for COVID-19, and we were very pleased to see it was. But then it still took some time to get through all the processing to be released.
Of course, as is usual. So what's your guess then on this one, on the results?
Oh, okay, I would guess that there would be maybe a lot of people falling in that second bracket and the third bracket. So sort of aware of it but not used it, or read it but are still looking to apply it, because it's still relatively new, and there's a lot of information and changes required really to adopt it.
There's a bit of a spread actually. So there's some that have been. Well, I'll end it now and I'll share it with you so you can see the results. So few people using it already. Some have read it, not actually applying it yet, and then quite a few, as you might expect, aware of its existence but haven't done anything with it yet, and another few that are not familiar at all with it. So so this is quite timely, really, that we're looking at this now in the context of outbreaks, and interesting to know that you had to review the content in the light of COVID-19 to make sure it was still valid. But so that's good.
Yeah.
Okay. I'll stop that one then. Thanks for that, everybody, for answering. Thanks, Jane. And I'll hand back to you.
Yeah. Thank you. So that doesn't surprise me. I'm sure you've all been extremely busy with the COVID response, and the manuals are quite lengthy. And there's a lot of information in there. So if we just go, so it's great to know that I'm talking to the right kind of audience, and I'll be also interested to the people who've started utilizing it as well. So this is the 4th version of the manual, and it was published in late last year. So the first version was published in 1983. And included the risk groups 1, 2, 3, and 4, and but not the biosafety level 1, 2, 3, 4. The classification was actually basic, or a containment lab, a maximum containment lab, and in effect we're going back to that kind of system. But I don't think that first manual had all the context and help and sort of guidance and templates that would help you to make those assessments of which style of laboratory is applicable for you. Obviously, the techniques that were used back in the 1980s was extremely different from the techniques that we're using now, and also the culture in the laboratories. I mean, how people behaved. There was smoking in labs. There's a very hierarchical systems in labs, and the incidence in the labs of laboratory-acquired diseases, but it was generally high at that time, which is why the biosafety manual was written in the first place. So the manual has evolved since that time, but the third manual was published in 2004. And if you think about the sort of technical evolution that we've had or revolution we've had within the laboratories system since that time, then it was and also the lessons learned from Ebola response, which I'll go into in a bit, that it was felt that the biosafety manual needed review. It was felt really that it was serving countries, sort of the richer countries, but not the poorer countries. And it was the manual itself and the way it's set out was driving donor countries to provide laboratories that weren't sustainable in many of the countries where these laboratories were given. So I worked in a project in Azerbaijan, where the Americans were providing biosafety level 2 laboratories to nine. They produced 9 different labs across Azerbaijan, and they applied the Washington Post test when they were designing their laboratories. So the Washington Post is a famous paper in America, and they thought that if there was an incident or something in America, in the labs that the Americans had provided in Azerbaijan, and they hadn't provided all of the facilities you would expect in America, that the whole project would be criticized for providing substandard laboratories. And so it was this sort of theory that said that if donors are providing labs, they should be the same as the labs that are used in the donor country. So this built a paradox, which this Chatham House article there summarized, and it said that the paradox is between endemicity and resources. So countries with high endemicity of pathogenic agents have low and often intermittent resources and capacities. Meanwhile, countries with low endemicity have high containment facilities with costly infrastructure and maintenance. So the common practice of exporting these high containment facilities and standards is not sustainable, and so it needs to be reconsidered whilst still maintaining biosafety and biosecurity within these agents, so within these regions. So we need laboratories that are fit for purpose. And the WHO weren't sure really that even in the developed or the richer countries, that these BSL-3 and BSL-4 facilities were serving their communities well either. So this survey by Wirtz showed that most the causes of laboratory-acquired infections was largely due to human errors, and not due to and that the technical facilities that we had were working well, but and can be so using procedures, techniques, and containment devices and facilities and training personnel are what is required to reduce the risk of working with these pathogens. And this is another study that looked at the root causes of accidents and near misses in Canada, and they found that 81% of these incidents were due to human or procedural errors, and very few were due to equipment failures. So we can see it's sort of communication. So this is often where samples have a higher risk appropriated to them, but that information isn't given to the laboratory scientists, so they don't know to increase the, to handle them inside of a cabinet. It can be human interaction, so people deviating from an SOP, or making a genuine mistake through lack of concentration or error. It can be that there's not proper supervision, or the policies and procedures are old and out of date and aren't current, or the risk assessments are inadequate. It could be that the training isn't fit for purpose, so either it's not in place, or it's not done timely enough, or and so the staff aren't proficient or qualified to do the tasks they're doing. And it could be that SOPs are very generic, not specific enough, so they don't actually describe the technique that people are doing. And then there's always a few others there. So when the safety manual was being reviewed, these were the sort of points that were borne in mind. So we're still having accidents, near misses, laboratory acquired infections, despite the highly sophisticated microbiology labs. And we need to remember that these high containment laboratories are really mainly looking at minimizing the risk of aerosol spread, but there's other routes of infection such as needle sticks or mucosal spread or whatever that are purely controlled by procedural and training and the way that people are working. And there's lots of confusion between risk groups and nomenclature and how different countries use this. So on the right hand side here we've got some information there, and that the previous manual didn't recognize that different countries have different cultures, climates, requirements and resources. It was a one size fits all, and it's not taking into account sustainability of these labs and how to make sure that they are going to be used and don't become a white elephant. So the conclusion is that one size approach does not fit all. The WHO guidelines need to be applicable worldwide. And so we should be going back to that basic question of what do we need to perform the activities safely and securely. And when we look at the lessons learned from the Ebola outbreak in West Africa, so we can see that on this picture on the left is the laboratory we have upstairs here. It's a containment line of a CL4 laboratory, where all the pathogens are handled in this sort of chain of class 3 cabinets. The European and American sort of system tends to be containing the individual, so suiting the individual and then working in a hot lab system. And research systems will be done for Ebola in laboratories like this. But in West Africa, we had scientists working very safely in tents, so there was no fumigation possible, no autoclaves present, no HEPA filtered and no lobbies often. But for the diagnostic work, that could be done safely. So, this led us to review that although you're working with the same agent, you need to look closely at what work you're going to do and arrange the laboratory infrastructure ready for that. So just looking at the UK system, we would have a hazard group, which would, from that, we would do a risk assessment and infer the containment level. The agents are classified nationally. There would be prescriptive measures, but we've got a wide difference in risk within those groups, and it leads to a checklist approach. So what the WHO are working towards is having a risk assessment approach for all activities based on the agent characteristics, activities, facility requirements, and your local and national circumstances, and then have a risk-based mitigation based on those resources. So this is their solution. So we have the main biosafety manual here, which is the first one, which is supported by 7 different monographs here, which looks then in more detail at safety management, risk assessment, cabinets, PPE, laboratory design, decontamination, and then outbreak preparedness. And then there's this supplementary guidance on biosecurity. So there's a lot of information there for you to look at. So I want to go through about how WHO think you should use these monographs. So they are very keen that these new monographs don't undermine existing national regulations. So you are still to implement your existing regulations at the national level, but the manual is to serve as guidelines and resources for biosafety professionals to use when you're planning and constructing, commissioning laboratories, implementing safety programs, doing your risk assessments and deciding appropriate mitigation and decontamination of waste and outbreak response. And the monograph contains some really good templates and things that you can use there. And underlying all of it is good microbiological practices and procedures. So going back to you know, what led to all of those incidents in the reviews seen by in Canada, but would take place in lots of labs, is that maybe there's too much reliance on equipment, and the training and the sort of professionalism of the technician has not been maintained. And so we need to have this emphasis back on good microbiological practice so that everybody is working well and controlling the agent at source. Because even the best designed and most engineered laboratory can be, those safety protocols can be undermined if you're using poor microbiological practice. Okay. So the manual recommends that we have a program management where you do your planning, your risk assessing, and this is led by a team, including biosafety officers, that you do your assessments of your work and what requirements are needed to do the work safely. And then you start your implementation and your monitoring to make it so with your SOPs and your safe working practices and making sure your equipment is working properly, etc. And then this is reviewed to make sure it's still fit for purpose, there hasn't been any drift in the project. And so you get this virtual cycle of continual improvement within your laboratory system. So with the risk assessment, it's a system that you will most likely be familiar with, where we're looking at the hazards, so things with the potential to cause harm, and then the risk, so which is the likelihood and the consequence of that harm happening. So first of all, you gather the information about the hazards that you're working with, and then you evaluate the risks associated with them. Then you look at the control strategies, and then select and implement those controls, and have a continual review to check that those are adequate and working properly. So the laboratory facilities in your risk assessment is going to be needs to be defined and appropriate to the work you're doing. And this diagram is really quite helpful. So we look at the most risky procedures being those done with live propagation of animals. So you're amplifying, growing up agents, or large scale production with pathogenic strains of your agents. And the risk decreases if you're doing in vitro propagation that's more controllable than your animals, you're using less pathogenic strains and smaller volumes. And your least risky procedures are those where you're inactivating your samples and just using compounds or components of those pathogens, or completely inactivated strains in very small volumes. And so you need to look at your biological materials, the type of procedures you're doing, and then you can define the type of equipment and the facilities and the amount of training and scrutiny and support that is needed for your work, and look at your national perception of risk associated with these different tasks. And so to help you do that and to do a systematic review of these risks and to decide the appropriate controls, the manual on the monograph on risk assessment provides these annexes, and there's a short template for risk assessment and a long template for risk assessment. And there's also completed example templates, which are really useful so that you can benchmark your risk assessments with the WHO ones that they've produced. And unfortunately, I don't think I've got time to go through this whole procedure. But if you're, I think that would be a little course in itself. But what I recommend is that you look at the monograph on risk assessment, which I've got here. It's really well written, really good, and that will take you through the different stages of gathering the information, evaluating the risks, deciding where, without any controls, it fits on this risk matrix from being very high to very low, and then you can then develop your risk control strategy, identify your control measures, and then reevaluate with the control measures, where does it sit? And then it's introducing this concept of residual risk, so that which I'll explain in a minute. And then the last section is on reviewing and authorization. So when you look at your risks and when you've got your mitigation, where it falls in this risk matrix, where you're looking at consequence versus likelihood, if it's a low one, then a core basic laboratory would be deemed fit for purpose. And that would be the majority of work. There'll be some work which is of which would have either high consequence or is more likely to happen, where we'd need heightened control, and very small amounts of work that would need the maximum containment laboratories. So nothing is without risk. So when we start with a task without the control measures, there will be a very high level of risk. We're working with the agent, we are manipulating it, and we are, you know, we're having people in close proximity. But when we put our control measures in place, we reduce the risk. And so an assessment needs to be made as, is that an acceptable residual risk? And then if it's not, then we need to spend more money, put more controls in place, more training, etc., to make sure that the residual risk is acceptable. And this allows for a bit of context between countries. So if it's endemic, if the agent's endemic in your country, then the acceptable residual risk may be higher than if the agent has never been in your country before, because the general population will be exposed to that risk in their everyday activities. So this allows some more context to be taken in place. And the manual then goes on to describe and give outlines of typical laboratories with the core, heightened, and maximum containment laboratories, where in the core labs, most of the work is done on the bench. In the heightened, it's mostly in the cabinets, and in the maximum, there's no handling on the open benches, and any centrifugation is done with safety buckets. There's 2 methods of inactivation before samples are processed to other laboratories, and an autoclave would always be present. But this allows you to select the most appropriate lab for the work, not based on some assessment done in a different country that has different a different society and different endemicity of the disease. And I quickly just wanted to describe these sort of 2 different workflows. So in our Ebola laboratory that PHE had at the time, we were working with this glove box laboratory system, where the red shows the toxic pathogen. It's contained in 3 layers when it's sent to the laboratory, and it's opened inside the flexible film isolator under negative pressure, and it's has its first stage of inactivation within there. So we see the colour and the intensity of the agent reducing there to show it sort of had its first inactivation. So the is highly controlled where the pathogenic agent is. We will be storing specimens, so there'll be a storage area which is counted as toxic, and we need waste to be highly controlled, and that's toxic until it's made safe. But after surface disinfection, these samples can be brought out onto the bench and then worked on the equipment and fully inactivated and processed. And so the PPE for these labs is fairly light touch. It's normally gloves and laboratory coat and eye protection when working with chemicals, because all the infectious work is done behind a solid wall. Whereas in the hot room laboratory, again, your samples come in triple layered. They're worked on in open cabinets, such as a class 2 cabinet or a very simple glove box. And then there's more requirement for PPE to mitigate against the risk of escape from these less efficient primary containment devices. So we would expect respiratory protection and full PPE suits. Samples are inactivated and lots of bleach or spray or disinfectant is used to then bring them out of the hot lab into to where the samples can then be processed. So this level of laboratory, or this philosophy of laboratory, tends to be able to be done on as long as you can maintain your cabinet, to require less infrastructure, because you've got a lab within a lab, whereas this infrastructure, sort of a higher amount of infrastructure is required for this type of lab. So the take-home points on the new laboratory safety manual is it's intended to prevent exposure and release, and to rely on a risk-based approach in a very structured way to allow countries to flex and to provide laboratories that are suitable for their situations. And it's very applicable to outbreak situations. The only thing I would say that needs changing here is that the risk assessments need to be reviewed more often, because it tends to, the conditions and the techniques you tend to do change much more rapidly in an outbreak situation. So the challenges to get the most out of this new manual is to raise awareness and to promote this risk-based approach, so it's done competently and confidently. And we need to share information globally about biosafety solutions and best practices, so that sort of lower cost but still fit for purpose solutions can be used. So I've given you a brief overview. I'm really interested to hear what your initial reaction is to this. So thank you, John. So what do you think, what advantages do you think we have to partners for introducing this level for this new manual? So you're welcome to disagree and say that it offers no advantages, and then I put some possible advantages there. You might have other comments you want to make, which would be very interesting to know too. Is this multiple choice, John?
Unfortunately, Jane, I tried to edit this into multiple choice on the fly when we were talking years ago, but it wouldn't allow it. So we're going to get this. We're going to get a top answer.
Yeah.
So
well, that's still good to know.
I think it's interesting to see which of the elements that people select. So I'm interested. Can I just ask you a quick question while we're waiting for the poll to come through? So this concept of acceptable residual risk, and I can see how that's tied to the level of endemicity of a particular pathogen in a country or an environment. So do you think that residual risk will change over a period of time? I'm thinking about SARS-CoV-2, the current outbreak, where I mean it was at the beginning it was like, you know, panic stations, but now do you see that acceptable residual risk changing, or the perception of that risk changing over time?
So it's so dependent on your country, isn't it? So if you're in Australia or New Zealand or Singapore or other countries where they've worked so hard on excluding the virus, then and in countries where and in other countries where they haven't had much vaccine opportunities to be vaccinated, then their risk assessment is going to be very different to countries where they've got widespread vaccination and communities have been living with the virus for a long time. So it's so based on culture and situation. You're never going to get an international consensus on this.
But it also implies, I suppose it also implies that you need to revisit that risk assessment on a regular basis.
Absolutely. So in a minute, I'm going to talk about how we're doing testings on new variants. And so when we've got variants that are coming in that are that our population haven't seen, then we need a higher level of control. So even within one outbreak, we will have different levels of risk tolerance. Yeah.
So my guess on this, on the correct answer, or the most popular answer here, is to encourage risk-based approach. But I have to say that I'm cheating because I can see that on the screen. So there we go. Here it is.
Yeah. Okay. Well, what I was hoping.
But no disagreements.
No. Hooray! Well done, everybody. Well, no, yeah, maybe I've been very persuasive. My favourite one, well, is the encourage risk-based approach and more flexible and globally applicable. So yeah, that's
okay.
We've got 71% of the audience agreeing, so perfect.
Excellent. There you go. Okay, great. So yeah, let's move on. Thank you.
Okay. All right. So that was a really nice discussion, John. Thank you on risk tolerance. And so countries and the UK will issue a national risk assessment. So they look to see what are the main threats to the country. And this allows organisations and to know what they should be preparing for. And you can see that human and animal disease, either naturally acquired or deliberate release, features highly on the UK risk assessment, which means that we should be doing all this pre-outbreak preparedness. So this pre-outbreak preparedness is ongoing surveillance systems in place at the local, country and international levels to look and monitor potential outbreaks. And that we've got the laboratories are doing improved research into improved detection methods, models to understand the pathogenicity and transmission routes should an emerging pathogen arise, and then look at prophylaxis and post-disease treatments, and have a cadre of well-trained laboratory staff and good laboratory facilities in order to do this. So we'll have a mixture of diagnostic laboratories. This is a SARS one, so the initial inactivation or sample processing is done in cabinets. Once it's inactivated, it's on the bench, and then we've been using these large machines to do the actual processing. And then research laboratories. Have we got this question, John?
Yeah, bear with me. I think I've got this one somewhere.
So I'm just interested to know if you are doing research as well as the diagnostics, and what type of research you've been undertaking.
Yeah, I did. I managed to get this one. I think I've allowed multiple choice.
Okay.
More by luck than judgment, I think. But anyway, here we go. There we are.
So when I previously described the different laboratories, you can see this picture is one of our research laboratories. So because we've got known agents, we're culturing them. So our risk is moving, on that diagram I had with the little mouse and the diagnostics methods, it's moving more to the left, to the high risk end, and so our labs are quite different. So let's have a look and see what people think.
Okay.
I've been
While
doing.
that's coming in, I just had a comment from Edson in the Philippines, and
Mm,
he says that in addition to the options, the LBM4 expands the control measure options for resource-limited settings. True,
mhm.
enabling them to implement effective biosafety strategy depending on the level of acceptable risk and available resources. So I think that actually summarizes exactly your
Brilliant.
points. Yeah, very
Yeah,
good.
yeah. Thank you for adding that.
Thanks, Edson. Thanks for that comment. If you can hear us, that's great. Okay. Still a few more answers coming in, Jane,
Mhm, mhm,
and quite a spread. I think that, unfortunately, with other, it's hard to say what people are going to come in with on other. But
yeah.
if those of you that answer other, if you're able to put something in the chat or the Q&A, that would be very helpful. If there's any points you want to raise while the poll is running.
John, whilst we're talking, I'm just aware of time and that
Yeah.
we've got sort of another 10 minutes left.
Okay.
So I'll
Well,
kind of.
don't rush. Don't speed through. I mean, I think
Okay.
we've got until 9:49. Yeah, we've probably got another 10 minutes. I will close it off at the 90-minute stage, which will be in 20 minutes time, or 10 minutes time, something like that. Yeah.
Mhm. Okay.
Let's go on quickly. There's the let me share the results. Quite a mixture.
Diagnostic methods, yes.
Yeah.
And then some others that I haven't suggested there. So that's interesting.
Yeah.
Okay.
Okay. Right.
Thank you.
Move on.
Mhm.
Thank you.
Right.
Let me stop that.
Okay,
Right.
so I was just going to give you an overview of the work that we've been doing. So some comes into this high risk work where we've been using animal models. And the hamster one is actually the most effective to look at new, to do the initial work on vaccines. And there's lots of vaccines that are now in common use that have passed through our labs for their initial safety trials, and also drugs and immunotherapies. And this work continues. And this is a sort of type of lab we would be housing our little hamsters in, and the people would be standing up in these sort of spacesuits to work inside a containment lab. And then we've been screening medicines for COVID, which requires having the medicine in contact with the virus, seeing if it works, putting it into little plates, growing it in cells to see how much of the active virus is left. Yeah, we found, so we've screened medicines doing this, found some really good medicines, including these llama nanobodies that have that seem really effective too. And then these have gone into animal studies and then preclinical trials. So we've been involved in producing some of these. The hydroxychloroquine seemed effective at this stage, but not when we went into the animal models and the clinical trials. Well, it didn't reach clinical trials because it wasn't effective then. We're also doing a lot of work on microneutralization assays. So this is where we test the ability of antibodies on the sera of people's blood to neutralize SARS-CoV-2. And we're having 2 great big new buildings done for this. We handle all the samples inside these class 3 cabinets here. And we are importing variants of concern from all around the world to see how effective immunity in our UK population is to these different variants, so that we to risk assess for the country how well protected the population is from other variants. This is some work that I was involved in. So lots of companies came up with lateral flow devices for testing, but when the scientists did the assays, they found that less than half of them were actually sensitive, or had the required sensitivity, specificity, and usability. We did the first trial in schools where we could show that they could be used in a non-clinical setting for asymptomatic testing. And now you can see on this graph, the blue is the level of PCR tests and the beige is the level of LFTs. So huge numbers of LFT tests being done nationally. We're also doing work on survival on different surfaces, serology, looking at and levels of antibody response in the population, We're doing 1,500 samples a day, sequencing them, so we can look for changes in circulating strains. And we're also got this PCR assay available too.
What's the Star Wars picture?
Oh, so this is so these are our scientists at a Christmas party, and so we're lots of geeks and we like science fiction, and it's a mixture. I put it in. It's a mixture of science of individuals and machines working in close harmony to produce the diagnostic systems and to do this research.
Okay, very good.
Yeah.
So we've got another poll coming, the final one,
Yeah.
which is I'll just launch it now. Unfortunately, I've restrained this to single choice, so
Okay.
we'll get a top answer. So which is the main issue for you? You've probably encountered all of these at some point, but which you think has been the most problematic from your point of view? Was it reagents, staff, containerware, waste management, sample transport, lab systems, and so on? I'd be interested to have a poll on that. I mean, time-wise, Jane, I mean, the audience is still with us. We haven't lost anybody, so I think that's a good indication of the relevance of what we've been talking about. So I know you haven't got a huge amount left, but I think we should proceed right through to the end.
Okay. All right. Thank you. So I can say that we've had all of these issues. We've had to upgrade everything. Reagents, we've had to has been a massive issue. Luckily, we've got a few manufacturers, such as Thermo Fisher, in the UK, and so we've been able to use those. But any supplies that have come from America or whatever, we've had huge problems trying to get enough through. So this is really interesting. So lack of reagents, yes. Lack of trained staff, yeah, I agree with. We've had to ramp up hugely and work all times of day and night, and it's been hugely stressful on trained staff. Lack of plastics, that's interesting. That hasn't been a major problem.
No.
Waste, we've had to prioritize waste, so we've been incinerating waste that we would normally autoclave.
Yeah.
Sample transport, that's not been a major issue. Lab information systems, we were lots of paper-based systems have had to go, have been upgraded, which has been really good. And I'll talk about some quality issues. So yeah. Thank you. Really
no,
good.
interesting, isn't it? Yeah, time, cost, and quality. It's the three things which get hit. So yeah, excellent. Okay, thanks for that, everybody, for voting on that. I'll hand back to Jane for the next few slides. That's the last poll, by the way.
Lovely. So just to show you some of the issues that we've had. So this is the PCR testing in the UK. So the blue lines indicate the testing that has been done over the 7-day rolling average, shown in the dark blue line, and then the capacity is shown in the silver line. So at the beginning, we had very limited capacity. It was 2,000 samples per day across the laboratories, and so basically we had to lock down, and we completely missed the first peak in the number of people infected. It couldn't be measured because we didn't have the facilities, and so there was a massive program to expand testing, and you can see that during this first phase it wasn't enough, and we came to this crunch point a year ago when the schools and universities were going back, and the system basically fell over because there just wasn't enough testing. And this is a theoretical maximum. This is if every machine is working 100% efficiently day and night. You're never going to really achieve that. Really, you need to think about 70% of your national capacity as actually being your capacity. So you can see, even, there's been times when it's getting a little bit tight even now, but we have got a good safety margin as more and more labs have been opened, and the supplies and resources have been stabilized. But we are having issues, and this is an issue that happened just 2 weeks ago in the UK, when this laboratory that had been set up 2 weeks, I think, before the outbreak first happened, so it didn't have a long track record. It was founded in May 2020, and it had been awarded a huge contract to do all this processing, and it's thought that 43,000 samples were reported as negative when they would have been positive, and this has led to increased incidence in in regions of the UK where people have been told that they were negative, even when they knew they'd been in contact and might have had some mild symptoms, and so have been circulating in the community, spreading the disease. And this, we've got quite a lot of society who don't believe in testing and vaccines, and then you get things like this, and it just really loses trust in scientists and the system. So yeah, it's even now, when you think that labs are going to be well practiced, the quality has still been a big issue. So in the UK, we had a system previously where we boasted about efficiency and cost effectiveness, and almost like a car plant thinking about just in time, and that labs should be working at this sort of close to 100% efficiency, and how many samples can you do? And that was how the science was measured. But it meant that the labs and the hospitals are stretched every winter. But surprisingly, you might think for the UK, which is such a large international economy, there was just a culture of poverty and a lack of investment in laboratories. We were continually having budgets cut and asked, not where do you need investment, but where can you make savings? And so when a pandemic hits, the UK had very little resilience to deal with an outbreak the scale of that COVID-19 has presented. And so we haven't done well. When we think about legacy and what happens next, so in West Africa, as a result of the COVID labs, there has been investment in laboratories. So this is sort of more, in keeping with the WHO Safety Manual 4 of a sustainable laboratory. And then the Canadians have built these huge, very complex laboratories in Sierra Leone and Nigeria. But the one in Sierra Leone, although it was built and imported before COVID, it wasn't certified. That takes a huge amount of time. And so it hasn't been able to be used for the COVID response. So it just kind of shows that maybe 10 of these or 20 of these is worth one of these type of laboratories. This is a UK facility that we have. So we've got a rapid response team with a lab in boxes that can be quickly shipped out, and a whole lot of techniques that can be supported from this facility. And this is the new infrastructure that the government have invested in as a legacy for the UK, and it's called the Rosalind Franklin Laboratory, and it has only just recently opened. So it's processing samples now. And basically there was this great big, they call it shed or warehouse, that was empty, and this has been turned into a laboratory infrastructure. So let me just show you what the design is like. So basically it has these lab lines, so it's very linear, and we've got and some of these lines have now opened to enable samples to be processed. So the samples will be shipped in here, they'll be unpackaged, they'll be inactivated within this line, and then the samples are taken through to the PCR suite. There's 3 of these where they will be processed. And the PCR that they're using, it's subject to patents and things, so I can't disclose, and I actually haven't been told myself all the ins and outs of it. But basically it's an endpoint PCR, so it's not giving the CT values or the quantitative amount of virus present, it's just the positive or negative, and it doesn't use so much plastic. So rather than placed in tubes. It's printed onto tape, and then the samples are injected into the little nodules, presumably, on this tape. So it's extremely fast throughput. It's similar techniques have been used in for animal diagnostics previously, and now it's being transferred to this to human health. And so its capacity is something like 20,000 samples per day that it can process. So it is it's here in the middle of the country. It's within 2 hours of most major airlines and 90% of the UK population, and so it can support testing across the world as capacity allows, creating employment. And here we've got plans for when the COVID actually reduces, that there will be a legacy lab, and they're talking about, because it's got the sequencing arm as well to it, is that they can do lots of sequencing studies for cancer diagnostics, and also looking at pre-disease diagnostics as well. So that will be the UK legacy. So this is my summary for you. I really do promote the Laboratory Biosafety Manual to you. I think it's got some great templates there for risk assessment, for guidance and advice, and how it can be applied in the outbreak situation. We need, as a community, to promote the requirement for funding in this pre-outbreak preparedness, so that laboratories across the world are being able to conduct the surveillance and research into therapeutics, vaccinations, and that we've got the lab capacity and trained staff to respond when needed. For us in the UK, we need a change in culture around general healthcare science, so that we've got robust systems in place, and that we've got the range of laboratories that allow us to respond to these outbreaks. So as us as scientists, we need to engage with those politicians, government and public, so that our work and our positive response to threats such as we're under now can be are appreciated and supported. Okay, so thank you all very much for your attention.
Jane, thank you very much indeed. That was brilliant. I mean, I'm conscious we are seriously over time now. That's my fault for probably interjecting too much. So we had one final comment that I just want to comment on that came through from Melissa in Singapore, who noticed a wave-like trend in the PCR test. You know, in your previous graph, there was a wave-like trend. I suspect that was to do with the wave in the infections, that the number of infections. Is that fair to say? If we go back quickly up there, that's right there. Yeah, okay. I can see what you mean. Yeah.
So we had a lockdown here in early January, so that would have led to a decrease.
Yeah.
And then we had an opening up in July, which would then have led to an increase. And we are here now, and rates are high, but we've got good vaccination rates, so admissions to hospitals are deemed acceptable at the moment. But yes, you're quite right, there are waves, and it depends, it will relate to lockdowns and other interventions.
Okay, well, Jane, I think we ought to let these good delegates go and get go and see their loved ones and get something to eat, because I think it's going home time in Southeast Asia just now. So I won't extend the length of the webinar any longer. If there are any questions or comments that you want to forward to me, please do that, and I can pick them up with Jane subsequently to this webinar. You will receive a feedback form when you log out. I'd encourage you to fill that in, because there's an opportunity there to ask questions and comments also that will arrive automatically into your inbox. Our next webinar in the series will be at the end of November. I'll circulate the date soon, and that will be on the sequencing and detection of novel pathogens. So we're going to have a look at some of the techniques for I think metagenomic sequencing and identification of pathogens in wastewater. So we'll have a look at that in a bit more detail at the end of November. So I'm sorry we can't spend any more time talking about this. I'd love to spend a lot more, but we can't. So I wish you all well. Thank you all for attending. Thank you so much to Jane for that excellent presentation. And I look forward to seeing you all again soon. Best wishes. Bye. Bye for now.